next one we got on our list of what we're going to do is to try and start building up our understanding of pain and actually the experience of pain, what it's all about, because often that's the key thing for people, is understanding why, isn't it? Yeah. So we're going to build it up gradually. I'm going to start at a very simple level, okay, because I think often that's the best way to build up our understanding. Start small, build up. You can go away, read up more and build up your understanding, but we're going to start simple. So I make no apologies for that, okay, and you'll know that when I start drawing as well. It's simple, okay. But the thing is, we can build from it. The other thing is our understanding of pain, how we experience pain, what's going on, is developing as well, all right? Over the years, research has now been coming up that we're knowing much more about what's going on in the brain and in the nervous system. So again, it's something that we're building up our knowledge generally within the medical profession as well, okay? Key thing though, often first off, is just being clear on different definitions around pain, because I'm sure you've heard a lot of those. Yeah? So let's just make sure we're clear on what's going on. What do we mean by acute pain compared to chronic pain, for example?
Minor, major.
Minor, major. Yeah, and it's often language really gives us that, doesn't it? Because chronic has got a sort of major, or, you know, a real sort of long term is another phrase. And term is the thing, because it's time. Yeah, it's time related chronic, but English language gives it a sense of, oh, more major, more terrible, when it's not, it's time related. That's actually it. So long term is a better word actually, if you think about it. It's a long term pain because it's going on longer than acute pain. Acute pain relates to the healing times of tissues. So if pain goes on longer than the healing time of the tissue, then we're looking at chronic, long-term pain. It's just gone on longer than expected. Yeah? So if you think about if you damage skin, how long does it take to heal? About a week, isn't it? You know, and you've seen a scab forming and it's doing quite well. Tendons, ligaments, sprained ankles, take a bit longer, don't they? Yeah, you're looking weeks more, aren't you? And you need a bit of rehab there as well to get going. Bones are the longest things to heal. Yeah, what time are we looking at for bones healing? 6 weeks upper limb, 12 weeks lower limb. Okay, 12 weeks for the lower limb. All right, so you've got definite time scales. So if it's going on longer, long-term pain. But how do we actually feel pain? What's going on? It's related, as we were talking about, nerves, nervous system. That's what it's all relating to. So, I told you I wasn't very good at drawing, but we get basic. Brain, spinal cord. That is our central nervous system. Really, really key thing for our functioning. That's why it's protected so well. So we've got our skull protecting our brain. The spinal cord is protected by what?
Spinal column.
Spinal column, all those bones, all those vertebrae going up are there, giving us a protection. It's strong, it's a real strong structure, well protected. And that's because it's part of our, what we call our central nervous system. CNS, they often term it as. Then you've got all the nerves that are coming out at the different levels of the spinal cord, yeah, and taking it down our arms, around our trunk, down our legs. And that's called the peripheral nervous system, PNS. Okay, and that's often important that you'll find a lot of the tests and investigations are trying to work out what's going on and at what level of the nervous system. That's what they're doing, all right, is finding out more information. So let's try and take it through bit by bit what's happening. The easiest pain to understand is one that happens and we get a quick response. So if I give you the example of putting my hand on a hot plate, yeah, silly thing to do, yeah, and we get a response, yeah, and that response most probably will be what? Ouch, and whoosh, whisk my hand off. Yeah, there might be some other words coming out as well. Yeah, yeah.
Probably none of them beginning with O.
All right. So we've got little things picking up heat receptors, okay? And that message is then going to go whoosh all the way up to the brain. So this side of our body is picking up senses. So it's called the sensory system. As well as temperature, we've got things for chemicals, picking up inflammation, chemical receptors, we've got touch receptors, we've got pain receptors, we've got pressure receptors, all these different things that can take that message up, vibration, all these different things it's picking up. But then what goes on is the interesting thing, because the brain is basically making a decision. So we call that processing. So it's receiving information and then it's deciding what it does. And you've told me that that response would be coming down, and it might be taking a message down to, that's my drawing of a muscle, and it would make the muscle work and I'd pull my hand away. Yeah? And that's called motor. And it's coming down muscles and glands actually as well, organs in our body as well. We can get the messages going down to it. And the muscles, it's moving my hand away, but it's also operating the muscles in my mouth for those words that are coming out as well. So that's a very simple understanding. And in the olden days, in history, that was very much how they understood it. It's just, you know, one way up, one way down. And it's simple, yeah, we can understand that. But we now know it's a lot more complicated, yeah? But it gives us that sort of point of understanding. So let's break it down a little bit more for you. We know this looks like, often people use a way of thinking about it like electrical wires and like an electrical current going up all these wires and coming back down again, which is a good way of thinking about it. But what we know is it's not whoosh, it's not like a quick response up. There are actually sort of holding points as we go through. So if I sort of took that away a little bit, what we know is there's like these little holding bays before it goes up. And these little holding bays are called synapses. Anyone heard of those little words? But they're really important because they have chemicals. And the chemicals are actually showing or explaining what's going on in the system. But remember, chemicals can also be the way that we can impact on the system through medication. Yeah, because chemicals, anything that's chemical, that's where your medications are going to affect it. So, what's happening with the synapse? I would describe it like this. If you think I'm the pain impulse travelling up, yeah, goes at different speeds as well. But I'm travelling up and I get to a synapse and it's basically a stopping point for me. I've got to wait until the chemicals come in, which will increase the threshold, and then I can go through. and I can pass to the next one. Yeah? And then it goes to the next synapse, to the next synapse. But it's got this little holding bay. And we know that it's different. People's pain thresholds are different, aren't they? You can know that from your own experiences. So can you start to understand as well? That's why pain is such an individual thing, isn't it? Because everybody's got different threshold levels. Some people get there and it takes ages and ages and ages before their impulse goes through. Well, other people can feel something and it's terrible pain straight away. Yeah? So it's something's going on at that synapse level. All right? Also, if you think about it, if you've got an impulse that's coming up on these pain pathways, if it's doing it over and over and over again, when it gets to this synapse, what do you think is going to be happening? Is it going to wait a long time to build up, or is it going to think, oh, I know this, straight past? Yeah? So because pain is going on for a longer length of time, those synapses are like awash with those chemicals. They're so used to it that the pain impulses just whiz off straight away. Yeah? Off they go, off they go, off they go, straight to the brain. So you're not getting like a holding bay so much, yeah? The message is going straight up. So that's important because it depends on the amount of information the brain's got, doesn't it, for how it processes it and makes its decision. Because if it's saying, I'm getting this impulse over and over and over again, compared to, oh, that's unusual, that's different, I haven't had this impulse for a while, the output would be different. Would you go along with that?
What happens if, mainly asking, what happens if you're in pain continuously?
Yeah,
I'm on painkillers, but it never kills the pain. I'm in pain all the time.
Yeah.
I wouldn't know all it was to wake up without pain.
Yes.
So how would that work then? We're going through an impulse.
So no, we're going up to this level more now. What's going on in the spinal cord? Because the other things we know is that as the impulses go up, there's an opportunity, if you like, at the spinal cord for the messages to be dampened down, or they can be amplified and increased up. So one way of describing it is like a switch stuck on high. Yeah? That it's just, if you like, got, and it's the word they used, is sensitise. That the system has got so used to those impulses coming up all the time, it's like the switch is stuck on high. It's just always happening, it's always happening, so it never goes lower, it's just got stuck on high. Does that make sense? Yeah? And, you know, if you think about it, the output as well, what is pain? Pain is a perception. It's an output of the brain. Yeah? So it's very real. It's to do with our biology. But instead of the output being moving your muscle, the output from the brain is perception of pain. Because if you look at it, what's the body trying to do when we have pain? It's trying to say...
It's trying to warn you.
It's trying to warn you. Absolutely. It's a warning system, isn't it? High alert, warning, danger. Yeah? You want your switch on high then. But if it stays on high, because the system's got used to it all the time, your body is perceiving danger, danger, but it's not there anymore. And that's what they're talking about, sensitised. The system is sensitised, the sensitivity of the nervous system. Yeah? So this is one way that they're starting to look at it. Another way that people describe it is like a burglar alarm being stuck ringing. It's like danger, 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 and the alarm's never gone off. It's like your sensitised central nervous system has always got the alarm going on. Yeah? So that's how we're building up our understanding of what's going on. And if we use some examples to think about it, it deepens our understanding even more. Because Tony, you were mentioning the phantom limb pain. So in that situation, have we got the receptors down in the leg?
No.
We haven't got them. That amputation, that's taken away, but that person is still perceiving pain. And they don't just feel pain, they often feel itches, different sensations down in that area. So the receptors aren't there, but that message is still going on. We know that it tends to happen a lot more when people have pain before the amputation. So that goes on with this message, isn't it? That the body system has got so used to it, even though this is gone, the message is still being generated, the brain is still perceiving threat, alert, on high, pain. But it's phantom limb pain. The limb's not there, but they're still feeling the pain. Yeah, so it helps you understand why. Another way that it helps us understand the complexity of this system, what happens in emergencies to perception of pain? On the battlefield, what do soldiers often report?
Feeling numb.
Numb. Do they have pain? They might not. They might be in catastrophic situations, but they don't feel the pain. Yeah? So what, in the emergency, we're on huge, high threat alert, what's being produced?
Adrenaline.
Glands. Adrenaline.
Fight or flight.
Fight and flight, you've got it. Yeah. So we know that's going to have an impact on this, don't we? Yeah. Any other things that our body can produce to help with pain?
Endorphins.
Endorphins. And how do we generate those?
In the brain.
Brain. And exercise, we know, is a big part of helping to get endorphin levels up. And they're, if you like, your natural painkillers. Okay? So they're going to have, we know, have an impact on this system. Yeah? What about any memory that you have around pain? Do you think that's going to impact on this system? Your thoughts?
You might think I'm not doing that again because it hurts.
Ooh. If you're fearful of doing a movement, do you think that's going to have an impact on your perception of pain? If you associate that movement, so for example, you know, when you injured your back, if you were bending, do you feel a bit hesitant, a bit nervous about bending down? So that's your thoughts reeling. Oh, I could hurt myself again. Your emotions of fear coming out is having an effect on this system. So the brain processes all that information, output, pain, danger, danger, high alert. Yeah? So we know that these things can be impacting on it. Does your mood impact on this? If you wake up and you're in a real positive mood, you know, going for things, compared to times when you wake up, you're feeling really low, difficult to get moving, do you notice a difference in your pain perceptions?
Also, stress can make the pain worse.
There you go. Yeah. So all of those factors are impacting on how we're perceiving pain. Yeah, because there's times when, as you said, you're feeling, you know, it can vary, can't it? So what are you doing? Putting the switch more to a lower level? Let's put it down there. Are these the things that we're starting to cover in the programme? Looking at stress management, thinking around your mood, your emotions, remember your hot cross bun, looking at that impact. We're going to be doing more on thoughts.
Could you retrain your brain?
Yeah. And how do we retrain? What do we need to do?
There is a word for it and I can't think of it.
Well, if you're doing any type of training, you've got practice, haven't you? So practice. Because the one thing about the central nervous system, we know it needs repetition. It needs repetition. So you're right, if we want to retrain it in some way, we've got to have some repetition going on. Yeah? Okay? Because what we're looking at, if you like, at a basic level, is the input into the system will create an output. So the central nervous system is very adaptive. If it's got different things going on, it adapts. I've seen it very much with injury to the system. It's got a huge potential to adapt. And if one pathway is not possible, often the brain finds another way. You know, it's very adaptive, this system. And we also know it needs repetition. Yeah, that was the key thing as well. So if we've got repetition, we've got an opportunity to retrain. Yeah. That gives us a bit of an opportunity then, doesn't it? Yeah, because there's a possibility. Yeah, the central nervous system can adapt, it can change. It's got the capability to make changes. And if we approach it from lots of different directions, you've got more chance of having an impact on this highly sensitised central nervous system. Does that make sense? Yeah. And it's not to say that you're not going to get acute pain, you know, which was very clear and understandable. But that's why the treatment for acute pain is very different, isn't it? Because you know what's going on, you can treat the pain. Yeah? But can you see now with the long-term pain, because we've got loads of other things that are affecting it, it's not a straightforward find it out, treat it, is it? It's much more complicated, and that's why we're approaching it from lots of different directions. Yeah? But it is a matter of trying. Try different things. See what response you get. It is a bit of, experimenting. The other key thing, I suppose, to pick up from this and what we've learnt as well, does pain necessarily mean there's damage down at the tissues? No. It doesn't, does it? Not with long-term pain. No. Because it can be generated in the system here. And that's a key message going away, all right? Because then, thinking around moving, because a lot of you, when they say around your sort of thoughts and those worries, you've been saying to me, I worry it would do more damage. I'm worried about moving. But it's not an indication of definite things going on at the tissue level.
What about when the original damage was done then?
More acute pain then, isn't it?
But does that damage completely recover of the original site?
The body again has got fantastic healing abilities. Yeah, it heals with scar tissue. Scar tissue is never 100% as good as normal tissue, but it's a pretty good job.
But when it adheres to a nerve,
when you get adhesions and things like that, yeah, then it complicates, and it's sort of you've got to go slowly with things. Yeah.
What if the original injury keeps reoccurring? What happens then?
You're getting a bit of a mixed picture then, aren't you?
Yeah.
This is the thing. And like I say, and I think that's important to realise that you know, just because you've got a sort of chronic long-term pain picture doesn't mean to say that acute things can happen on top. And then you've got a mixed picture happening as well. Yeah, no, so it's a good point. All right. But hopefully it just helps you to see where things are and to put things in place. The other thing as well is to think our understanding of spinal cord. If we had a blockage here, somewhere along the spinal cord, you can see now what the impact would be. Yeah? If you get a total blockage, so I'm thinking of somebody who's had a spinal cord injury, paraplegic would be down here, tetraplegic, level up here. What's going to be happening? Are they going to receive impulses? No. Not below the level. They can receive it from up here, but they're not going to be getting it from down there. The paralysis is occurring because the message is not getting down.
What, not even with the phantom, sort of, if they've got a problem, like you just said, wouldn't they get, could they get phantom limb problems?
Not so much with spinal cord injuries, that's more with the amputations, yeah. So, you know, it's really important when we're rehabbing them, they've got to learn that they're not picking up this information from the senses, and therefore they've got to be on the lookout for things, yeah? But one way as well that it's been explained around the spinal cord is something called pain gate. Has anybody heard of that? Has anybody used TENS?
Yes.
Yeah? Because that's using that principle there. And they're talking about a gate sort of happening in the spinal cord. So you can see the gate open, things can go up it. We don't want the gate to shut fully, do we? Because we're going to have that, which is not going to be helpful. But if you close the gate a little bit, the argument is then, could that change what the brain is going to do? Because if it's pain impulses going on, if you close the gate a little bit, how many pain impulses would be going up? Less, wouldn't it? You'd take one out a bit, wouldn't you? Yeah? I'll rub him off. If you close the gate a bit, you're reducing the amount of pain impulses that are going up. Have any of you tried TENS? Yeah. How'd you get on with it? Didn't like it? It varies. You know, some people, they think, yeah, it works well.
What's the best setting to use?
They gave me more pain than what I was.
Varies depending on
'Cause I got
individuals. It's experimenting with it.
some of them are, there's so many different settings, I don't know which is the best one to use.
Okay, we can talk about that. But if we close the gate a little bit, can you see then you're getting less pain impulses going up? And the argument behind that is the TENS is giving you a different sensation. So different sensations are going up. So when the brain is organising what it's got to do, it's saying, well, I've got this information, I've got that information, and it's weighing them up. So that's what's going on when you think of explaining it in pain gate. The other way of explaining it is how many of you use distraction as a way of reducing your pain levels? Anybody get involved in a good book or a crafts, don't you? Yeah. You're using your distraction, aren't you, to good effect. You're giving lots of other sensory information up to the brain, and then it's making its decision about what to do. And it could be, you can either look at it that the gate's closed a bit, or you could be looking, maybe that amplification switch has gone down a little bit. Yeah? So there's sort of different ways of describing it that you might hear it in sort of different terms. But that's sort of what's going on, that we're trying to get off the sort of setting on high and we're trying to get it reduced down a little bit. So if we pull that together, already in the last few weeks, have you been making changes? Have you been doing things differently?
Yeah.
Yeah. You all have, haven't you? You've all done something differently. So what have you changed? Your input. You've started changing some of the input. Now, if that involves doing something which maybe your emotions and your thoughts have led you not to do in the past, so for example, say a feared movement, and you're actually doing that movement a little bit that you weren't doing before, the brain's now receiving information from a part of your body that it hasn't been receiving information for a while. Yeah? If you've been exercising, yeah? So the brain's thinking, oh, hang on a minute, I haven't had information from these receptors in X muscle, in X place, you know, on my body. It starts then to reappraise and think about the output. And the output could be a change in your perception of pain, but it could be putting on all these other things as well. But the key thing is making changes, because you change your input, you've then got the potential to change your output. Yeah?
But what if it just reaffirms the fact you're in pain?
Yeah, one way. You've got to experiment then. Because you've gone one way, brick wall, didn't get there. Got to look at it from another way. Because we know within this system, lots of things influence it. So if one way doesn't work, try something else. Experiment. Experiment. Yeah? But the key thing again, I would say to you, repetition. The central nervous system learns, you can retrain it through repetition. But how are we going about that repetition? We've got to go about it slowly. Yeah? That if we go too quickly, what can happen to that switch? Yeah? But if we approach it slowly, you can allow this to be going on, reprocessing information, making adjustments. So just take it slowly, slowly. All right? Lots of nods. Yeah?
Yes, it's true what you're saying.
So building up that understanding, taking it in, you know, and it is a process, isn't it? It's not something you get straight away. It is something you build up your understanding with gradually over time. But hopefully that's the starting point for you in building up your information for yourself, what it's relating to you, because everybody's different. This is the other key factor, isn't it? We know, what we know about pain is very real. It's in the biology, it's in our system, it's real, but it's very individual, isn't it, as well? And you can see then, because of all these things are impacting on it, it's going to have even more of an individual focus, isn't it? But experiment. One person said to me after this talk, I'm going away, Jeanette, feeling a bit of hope. You know, the systems can adapt. The system, if we put change in, we can get a change out. So I would encourage you, experiment, find out. But it's very individual to you.